Hello and welcome. I'm Elisa Hernandez, a librarian at Stanford Health Library. Thank you for joining us for our talk, Knee Arthritis, a Lifestyle Medicine Approach. It's my pleasure to introduce our speaker, Dr. Michael Fredericson. Dr. Fredericson is a professor of physical medicine and rehabilitation at Stanford University and is the director of PM&R Sports Medicine in the Department of Orthopaedic Surgery. He's the co-director of the Stanford Longevity Center and the founder of Lifestyle Medicine. He is the head team physician for the Stanford track and field and swimming teams and a Tsai Human Performance Alliance member. Throughout the talk, please enter any questions you have into the Q&A box at the bottom of your screen. And at the end of the talk, Dr. Fredericson will answer as many of those as possible. Over to you, Dr. Fredericson.
Great. Well, thank you so much for the introduction, and thank you everybody for joining us this evening. Going to talk about knee arthritis, but a non-operative approach. So try to give you some tips on ways that you might be able to manage this. So just as a brief outline, briefly we'll go over what is osteoarthritis, and then discuss what I term a lifestyle medicine approach to treatment. And this will also include the role of different supplements and some newer injection treatments. But knee arthritis is having quite an impact on our population. Half of the world's population, age 65 and older, suffer from some form of osteoarthritis. And most of these cases occur in the knee. So I would guess that many of you listening tonight have some form of this. Now, one of the reasons that this is so common is just that we have an aging population, and also many people are overweight or even obese, and that can certainly be a contributing factor. Keep in mind that more than 790,000 total knee replacement surgeries are performed in the US early. So this is, growing exponentially. My job is sort of the non-operative person in our orthopedic group and sports medicine is to see if we can avoid this or at least prolong this while keeping you comfortable and active. Now, I have to say, if you do need a knee replacement, there's nothing to be scared of. It's a great operation, but I do see it as sort of a last resort. In terms of knee arthritis, what causes this? There's no single factor. There's a lot of different things that can contribute. It can be genetic predisposition, so it may just be something that you were born with a predisposition for. Could be age, it could be gender, could be even diet could affect it. Bone density. If you've had past injury or surgery to the joint, that can certainly be a factor. And then different types of biomechanical factors could be related to high body mass index, could be related to low or excessive physical activity levels. So as you can see, there's a lot of different things that can factor into that. And so for each one of you, it might be quite different. This is something we'll use in the clinic just to grade the degree of arthritis that you might have. All the way from grade 1 to grade 4. And essentially what we mean by arthritis, particularly osteoarthritis, is this area between the joint. That's where you have cartilage that protects your joint and allows your joint to freely move and glide. As that cartilage thins down, eventually you then have bone on bone. That's grade 4. That can be quite painful. So the simplest explanation for osteoarthritis is really just the thinning of the cartilage that's protecting the bones. What amazes me is that I'll have patients come in, and some of them are even bone on bone, and they just developed knee pain a couple weeks or months ago. And so I have some theories on why this is, but this is always very interesting. So my treatment approach, one is try and make people comfortable. What can we do to control pain, improve quality of life, improve functional movement patterns? Limit use as much as possible of pharmacologic medications, and ideally see if we can impact the progression of the disease. Why is lifestyle medicine approach important? Lifestyle medicine essentially is using things that are like nutrition, exercise, uh, controlling stress, getting proper sleep, maintaining healthy relationships. All these things fall under the umbrella of what we call lifestyle medicine. And in fact, lifestyle medicine is the largest growing professional organization now within the field of medicine. So you're probably hearing about it. You're certainly going to hear more about it in the future. Um, what's nice about most lifestyle medicine treatments is they have limited to no side effects. And most of these treatments will also benefit your overall health. This is just a sample of some of the things that we'll go over tonight. We'll go into each of these in more detail. I'm sure you've heard of some of these. Hopefully, a few things I'll mention tonight will be new for you. Probably the biggest thing, though, that you can do if you have knee arthritis is to exercise. And the research on this is pretty compelling. There's very strong evidence that low to moderate impact exercise can improve your pain, your physical function, and your quality of life. And of the different types of exercise, resistance training is clearly the most effective treatment regimen for pain relief, particularly in the older population. Now, I know you're probably saying, well, I wish I could exercise, but my knee hurts, so I can't. So, part of my goal in working with patients is how can we control the pain enough to allow you to exercise at least a low to moderate level? And what's uh, interesting with some of the new research that's coming out is that you can break up your exercise regimen into small, brief, like let's say you exercise 30 minutes a day. You could break that down into 3 10-minute sessions a day, and you're still going to get the same benefits as to one longer session. So this is oftentimes a more reasonable way for people to get in that exercise, particularly if they're busy. Um, Fit in 5 10 minutes here or there, or even incorporate it into some of the things you're doing, let's say around the house or in your yard. Let's just go over some of the other things that you can do. Tai Chi, I'm a big fan of. There are over 700 studies in the literature on all the different health benefits of Tai Chi, but definitely a number of studies showing that Tai Chi can improve pain and physical function in people who do have knee osteoarthritis. Getting in the water can be really helpful, whether it's swimming or one of these deep water exercise classes, or even just exercising in the water while you're standing. For instance, the YMCA has a lot of great classes for this. But being in the water is a great way to allow you to exercise your full range of motion, to maintain some strength. And it's also very good at helping decrease any inflammation in your joints. The other thing is braces. Sometimes we'll recommend these. This is what's called a valgus unloader brace. So let's say that your arthritis is more on the inner part of your knee, what we would call the medial part, but your outer part, the lateral, is still in good shape. So the idea of this brace is to take the stress off the medial component and put it more on the lateral where you can tolerate the loads better. And this is something you can wear while you're running or skiing or, exercising or throughout your everyday activities. Um, but it is definitely an option for patients. Another way to do this that's a little simpler is to actually put a wedge in your shoe. Now, this is mainly for patients who have this type of bowing in their legs, and they have that arthritis on the medial compartment. And so we put in that lateral wedge to try and bring those knees together, redistribute the loads better across the joint. The other thing is, how do you control inflammation? And studies have shown that systemic markers of inflammation, so inflammation throughout your body, that we can measure with different lab tests. One's called high sensitivity CRP or interleukin 17. And these are associated with inflammation, and particularly inflammation that's associated with knee osteoarthritis. So if there's a way to decrease the inflammation in your body, it can help you feel better overall, but also can help your knee pain. This is why I'm a really big favor of the anti-inflammatory diet. There's different diets that can help with this. What I like about the Mediterranean diet is that it gives you a fair amount of freedom. So definitely the cornerstone of it is, eat a lot of plant-based foods, vegetables, fruits, nuts, beans, whole grain foods. But it still allows a moderate amount of dairy, or if you want poultry, eggs, seafood. Even lean red meat is allowed occasionally. Now, this isn't to say that if you want to do, let's say, a purely plant-based diet, that you shouldn't. I just find that for a lot of my patients, this is a little bit more practical if they want to, they don't want to go purely plant-based. And the idea is that by decreasing the inflammation throughout your entire body, you're reducing those inflammatory proteins, or what we call cytokines, that play a role in knee osteoarthritis. The other benefit is that this type of diet can assist with weight loss. There's a nice study that came out of the UK looking at the Mediterranean diet, and they randomized patients with knee osteoarthritis to the Mediterranean diet or a control group over 16 weeks. And the patients who participated in the Mediterranean diet, one is they lost body mass. So for most of them, that was good because they were overweight. But it also reduced those inflammatory proteins, those cytokines. And it also reduced what's called serum cartilage, it's a big word here, oligomeric matrix protein, which is a marker that we can use to determine the progression of knee osteoarthritis. Now, I mentioned weight loss, and certainly in patients who are overweight and certainly obese, weight loss is really important in terms of improving your symptoms. Just a 10% weight reduction can improve function by 28%. I like to give this example to patients because I think it hits home. Just 1 pound of weight loss unloads 4 pounds of joint stress in the knee of patients with osteoarthritis. So that's equivalent to 4,800 pounds per mile walked. So it doesn't take a huge change in weight to have a big impact on the loads of your knee. And then going to different supplements. So you've probably heard about glucosamine and chondroitin. This is probably the most popular supplement out there, certainly for joint function. So glucosamine is basically a glucose molecule hooked up to a protein molecule. It's a water-soluble, what's called amino monosaccharide, and it helps regulate cartilage and the synthesis of synovial fluid that helps lubricate your joint. Now, chondroitin is another what's called glycoside, and this also provides the cartilage with some strength and elasticity. Now, the question always comes up, so just by taking a pill, is that going to actually get into my joints? And that, I think, is debatable. But there have been a number of studies that have looked at this. Probably the best study was done by sponsored by the National Institute of Health, and it was called the Glucosamine Chondroitin Arthritis Intervention Trial. And they looked at patients with moderate to severe pain and found that they did have statistically significant pain relief compared to those in a placebo group when taking the glucosamine and chondroitin. Now, other studies have had varying conclusions. And there's some thought that it might be related to the form of chondroitin used or the bioavailability. Some of the brands actually have a patent on the chondroitin, so it's a smaller molecule, it can be better absorbed. Now, does it actually build the cartilage, or does this more help with inflammation? In animal models, it does seem to help with cartilage. We don't have enough studies looking at this in humans. But what's interesting to me is that if you talk to veterinarians, they use this in, cats and dogs who have arthritis, and they feel better. So clearly something is happening here. And the side effects are really almost negligible. The other supplement I'm a really big fan of is turmeric or curcumin. And this is what we call a systematic review. So it took a number of studies that looked at this and found that it was pretty clear that just taking this supplement could reduce arthritis symptoms and result in improvements similar to taking non-steroidal anti-inflammatories. So taking turmeric can be equivalent to taking about 1,000 milligrams a day of ibuprofen. Again, without the typical side effects you would get from a non-steroidal or potential side effects. The FDA classifies turmeric and curcumin as generally recognizable and safe. Most common supplementation is 500 milligrams, 1 to 3 times per day. A lot of the brands will have some black pepper added to it, and this is felt to increase the bioavailability. But the side effects are quite minimal. You'd really have to overdo it to get some of these like diarrhea or a headache or rash or yellow stool. I find it pretty rare that my patients complain of this, though. The other thing you've probably heard about is collagen, and there are collagen supplements you can take. And several studies have shown that collagen is effective in improving joint mobility, decreasing joint stiffness, and decreasing pain. So again, it's a simple thing to do. You can just add it to your coffee in the morning or whatever you drink. Put it in a shake. But a lot of other benefits for collagen too, in terms of healthy skin, can help even heal some of soft tissue injuries. So, and even help you maintain, help you build strength while you're doing resistance training. Studies have shown that collagen supplementation may actually help with cartilage regeneration by increasing the synthesis of what's called cartilage matrix components. Now, just by taking collagen, I don't want you to think all of a sudden it's going to completely regenerate your cartilage. But all of these things taken together all can have a little effect. And then you put it, a little here, a little there, and you start, all of a sudden you notice that you're starting to feel better. The other thing about collagen supplementation is that it can protect against further joint damage by its influence on what's called the T regulatory cells, and also producing anti-inflammatory cytokines, so they can counterbalance the ones that cause inflammation. This is relatively new, at least it was new for me. It's called sativa oil or Nigella sativa oil. And this is one study that showed that it could actually affect blood markers of inflammation and oxidative stress and improve the quality of life in patients who do have knee arthritis. This was a very well done study, and they showed that 6 weeks of supplementation was quite effective in improving these inflammatory markers. And it worked both if you were using either the oral or the liquid form. Now let's go into some common medications that your physician may have recommended. Acetaminophen, trade name is Tylenol. but this is typically the first medication that physicians are going to give. It's less effective for pain and function than a non-steroidal anti-inflammatory, but the side effect potential is much less than taking a non-steroidal anti-inflammatory. It will give you some lower level short-term analgesia. And again, the adverse effects are quite minimal for short-term use. Like any medication, if you're taking it long-term, you do have to be concerned of some things. Now, non-steroidals, I tend to try and personally stay away from these. If I do use them, I'll just use them for a week or two at a time. Because if you take them long-term, not only could it give you something like an ulcer, but it could have effects on your kidneys or even your cardiovascular system. So as an alternative, a nice option is to do the topical nonsteroidals. And you can buy this over the counter now in just about every pharmacy. It's a topical gel or a cream, and you can rub over the area and put the anti-inflammatory effect right where you need it. And the chance of getting side effects is much less than taking the pill form. These are some other things that you might hear about or see in different supplements that could potentially reduce pain and inflammation. I would just say if you see these in the supplement you're taking, I would talk it over with your doctor because some of these could potentially interfere with other medications you're taking. So you just want to be a bit careful with that. And for the last part, I want to go into some injection options. And so there's different ways or different types of injections that we can offer, from corticosteroid medications to what's called hyaluronic acid to platelet-rich plasma, or what people call stem cells, but truth is they're not truly stem cells. So the newer term is now cell-based therapies. And two of the more popular ways to access that are through your bone marrow or through your fat. So corticosteroids are often recommended for patients who have knee arthritis and it's just not getting better with some of the things we've already talked about. The nice thing is you will feel better pretty quick after an injection of steroids. The problem is that it's not going to last that long. So usually it's not going to last more than about 6, at the most, maybe 12 weeks. The other concern with corticosteroid injections is just that if you do too many of these, it can actually wear down your cartilage. Now, in this study that was done through the National Institute of Health, it was a randomized clinical trial over 2 years, and they were giving patients injections every 3 months over 2 years, and they could see some cartilage loss. Now, even with that frequency, I have to say the amount of cartilage loss was quite small, and we would never inject somebody every 3 months in the clinic, at least I wouldn't. But still, I think if there are alternatives to steroids, it is something to consider. And that's where I often will recommend what it's called hyaluronic acid. This is something that's naturally produced in your knee. But as you develop arthritis, what happens is you have less of the hyaluronic acid, plus you have less of the more effective, higher molecular weight, the thicker type of gel. So they can now synthesize this in a lab, or you can actually make it from rooster comb. And it's like a thick gel, and we inject it in the joint. The nice thing is Medicare will actually approve of this and pay for it. Not every insurance, though, will always approve it if you're not on Medicare. But if it works, it's great because insurance will typically approve us doing this every 6 months. And a lot of my patients love it. It's just a great way to keep them going and active and keep their pain under control. This is a result of what we call a meta-analysis. So basically taking a number of studies and putting it together. And in doing this, this particular meta-analysis found that the hyaluronic acid was an effective intervention in treating knee osteoarthritis without increased risk of adverse side effects. And so the American Academy of Rheumatology has recommended it. At the very least, this is one study I was part of, and showing that by doing these injections, at the very least, we will delay the time it takes until you need a knee replacement surgery. But for many of my patients, I think it does help them actually avoid knee replacement surgery. One of the newer things, and you may have heard about, a lot of athletes are getting these types of injections, is called platelet-rich plasma. And this is where we actually take some of your own blood. And so if we take your blood, and it's made up of three main components. So you've got your red blood cells, you have white blood cells, and then you have platelets. And the idea is that we take the platelets and we concentrate those. The platelets are actually rich in what rich in your body's own natural inflammatory and factors and growth factors. So it's a very natural way to help control your symptoms. There's some thought that it might actually stimulate the stem cells to help regrow new cartilage. Again, this isn't a miracle cure. It's not going to give you completely brand new cartilage. But at the very least, it might help slow the progression. It might heal some smaller defects. But it also is very good at decreasing the inflammation in the joint. And studies have clearly shown that PRP injections can improve function, can help reduce your symptoms, and improve overall quality of life in patients with knee osteoarthritis. Like all of these treatments, though, the earlier we catch this and the less severe is the cartilage degeneration, the better are your results going to be. If somebody comes in and they're already bone on bone, this probably isn't going to work. So I would save your money, because this is one that insurance doesn't cover, and so there is an out-of-pocket cost to it. Now, there's still a lot of research going on in terms of platelet-rich plasma. So we still need further studies, but what is the best formulation that we're still trying to figure out? How many injections should you get? How often? This is one study that compared platelet-rich plasma versus hyaluronic acid. Now, the results were pretty comparable, although over time, the PRP, the platelet-rich plasma, did tend to work longer than the hyaluronic acid. So patients were still feeling better up to 12 months. And it probably worked a little bit better than the hyaluronic acid, but it wasn't a huge degree in terms of being that much better than that hyaluronic acid. So that's why I'll typically recommend the hyaluronic acid first. Number one, it gives you almost the same benefit of the PRP, but insurance will often pay for it as well. And then the question comes up, if you do get the platelet-rich plasma, how often, like how many injections? And so this has been an ongoing debate. This study literally just came out, so I wanted to share it. And they looked at patients who either had one injection, 3 injections a week apart, or 5 injections a week apart. And they looked at them over 52 weeks, so almost a year. And they found that getting 3 injections was better than getting 1, but getting 5 injections was no better than getting 3. So, in the ideal world, if you can afford it, probably getting 3 injections is going to give you better relief than 1. But this isn't something, again, that I'm routinely recommending, because I have to be concerned about the cost involved, and I don't want to have patients feel like, oh my gosh, you have to have 3 injections, because one can often give you quite a good amount of relief. Now, this is probably I would say, the newest area that you're starting to hear about. And people call it stem cells, and you even hear a lot of advertisements probably on the radio. Be very careful with this. This is still, we're still really doing newer research on this and learning about this. The truth is that none of these are therapies out there right now are probably true stem cells, but they're stimulating what are called the mesenchymal signaling cells. So it basically signals the cells that help control your stem cells. The idea being by stimulating these cells, they have pluripotentials, so they have the capacity to help regenerate tissue. Now, you can get these from 2 main sources, either your bone marrow or your own fat. And in terms of getting this from the bone marrow, this is done the same way they would get your bone marrow if you needed a bone marrow transplant. Let's say you had something like leukemia. So it's taken from the pelvic bone, the iliac crest. This can be done in an outpatient setting, but it is a bit of an involved procedure, and you definitely want to be numbed up well, because otherwise it could be quite painful. And then the other option is to take it from your fat. So this could be, a double benefit, right? So if you wanted to lose some fat, and then you can also use it for your injections. But I just want to urge some caution here, because the studies in terms of how effective are these newer injections, I think we're still trying to figure that out. This is a study that came out last year, and it compared a corticosteroid injection versus the bone marrow that I talked about, or the fat injection that I talked about, as well as what you may also hear about is taking this from amniotic membrane or amniotic fluid. And what they found is that all of them worked about the same. So there wasn't really a big difference between getting, quote, stem cell or these cell-based therapies versus something like a corticosteroid injection, at least in terms of pain relief and function. Now, this is a study that hasn't even been published yet, but the preliminary findings were published by what's called the Tsai Human Performance Alliance, and Stanford is the main hub for this. One of the sub-hubs is at the University of California, San Diego, where this research was done. And they compared the bone marrow versus the fat, and found that they actually have very different types of cell types, which makes you question, are they doing the same thing? And also they found that they didn't have very many proteins that you could link to regenerative function. So the typical proteins that we would want to see were really in very low amounts with these therapies. And so I just say this, I think there's a lot of potential for this, but I still think we're pretty early with the science. We'll probably look back 5, 10 years from now and say what we were doing, currently was, at a pretty basic level. But just be careful, because people are charging all kinds of exorbitant fees for these injections. And we still don't have a lot of research to back it up. It might work for you personally, but it's just not predictable yet. So just to finish up, and then we can get to some questions. There's really no pharmacologic agent that can actually halt knee osteoarthritis from progressing. So our goal is really to see if we can slow the progression and keep you active. And this is where offering a range of therapies that can help you take better control over the treatment process can be, I think, more effective. So combining a lifestyle medicine approach with some of these other things like the injections probably gives you the best bet at really living with this type of condition as long as possible. Just keep in mind, as I mentioned, that these biological treatments, they may slow down the progression of osteoarthritis, but if somebody tells you that they're going to give you completely regenerate your cartilage, that just isn't true. So thank you. And now I will turn it over and we can answer some questions.
Thank you, Dr. Fredericson. I'll be reading some questions out of the Q&A. Can you comment on the diagnosis of knee arthritis in people in their 20s?
So when you're younger, it would be unusual to develop what we call osteoarthritis. Now, rheumatoid arthritis is different. That's more something that can develop at a very young age, and it can be quite devastating. What we're talking about here is osteoarthritis. So that typically doesn't develop in a young age unless you've had trauma to the knee, which is going to set it off. But we're not typically dealing, I don't have many 20-year-olds or 30-year-olds come in with significant knee arthritis.
Thank you. Would the treatments that you commented on also relate to shoulder arthritis, or are they limited to knee arthritis?
Most of the things I talked about can help for, whether it's shoulder or hip, ankle, because a lot of what we're trying to do is control inflammation and give your joints the building blocks to help maintain healthy cartilage. Some of the injections, I would say most of these we can do in a joint like the shoulder, but we have the most experience doing them with the knees at this point.
Somebody is asking about Synvisc 1 and if that is an option that should be considered.
Right. So Synvisc 1 is hyaluronic acid, which I talked about. Synvisc 1 is made from rooster comb, and it is as effective as the hyaluronic acid that's made in a lab. The concern, though, with Synvisc 1 is that there is a subgroup of people who actually have an immune reaction to Synvisc 1 because it's made from this rooster comb. And the result is it creates even more inflammation. And it's really quite a mess when that happens, because you do an injection and the patient's then, calling you the next day or two, and like their knee is much worse. And so what do? Then we have to put in steroids to calm that down. So I'm not a big fan of Synvisc 1. If that's all your insurance will pay for, what I often will do, just to avoid the potential that this side effect could happen, is I will put in a little bit of corticosteroid just in case you react. We're already doing something to combat that reaction.
Thank you. Do you have any comments on the future of stem cell therapy and the future of implant treatments?
And what was the last one? The future of?
Implant treatments.
Oh, yeah. Like I said, we're going to look back at where we are now. We're certainly making great improvements and strides there all the time, but a lot of this is still at an infancy in terms of development. I think stem cells are the future. I just don't think we're there yet in terms of what we're really going to be able to offer patients. But I do think it is the future. In terms of the implants, so I'm the non-surgeon in our group, but the materials, the technique, I mean, those are always improving. And that's why I say if it comes down to having a knee replacement, a lot of my patients do end up with a knee replacement at some point. It's nothing to be afraid of. You actually you're going to do well. You'll probably be able to get back to a lot of activities that you can't currently do. But it is surgery, and there's always a risk with surgery. And not everybody has a great result with it. Most people do, but not everybody. And so, there is the risk that maybe you won't have a good result. So if you can avoid the surgery, great. But if not, again, don't be afraid of it.
Thank you. Any other questions? Please enter them into the Q&A now. Somebody asked, do you recommend working more on strengthening the quadriceps or the hamstrings to help knee osteoarthritis?
Right. So that's a really good question. You want to really strengthen both because you don't want an imbalance. If the quadriceps are much more powerful than the hamstrings, it leads to an imbalance, and that can lead to unequal stress on the knee. So ideally, you really want to strengthen both. I think there is more of an emphasis typically on the quadriceps, but it is important to strengthen both. It's also important to strengthen the hip muscles. We know that the hip actually has a tremendous impact on the knee. So keeping good hip strength can help maintain good alignment, and that can take stress off the knee. Also, maintaining good mobility and flexibility around your hip can be really important in terms of knee function. If your hip gets really tight and it can't move as well, then you're going to try and compensate by trying to get more mobility out of your knee, and that can lead to unequal stress in the knee and can actually exacerbate things.
Do you have any recommendations on the best types of shoes to wear?
Yeah, so partly depends on what your foot type is. Like, do you have a real flat foot? In which case you probably need a shoe that gives you better arch support. Or do you have a real high arch? In which case you need a shoe that's going to give you more cushioning. Or maybe you have just a normal, what we call a neutral arch, in which case a more neutral shoe will do, a little cushioning, a little support. Now, there is a shoe that was developed. I don't know if it's still being produced by one of our faculty, Tom Andriacchi, who ran the Stanford Biomotion Lab. And remember I talked about that lateral wedge can help some patients. You put it in your shoe. So he basically developed a shoe through a company called ABO, AEBO, the Biosystem. And that they basically, I think, bought the patent from him or something. But instead of giving you that lateral wedge, he basically built that into the shoe. So there was stiffness in the lateral part of the shoe. And that can be effective for patients with knee arthritis. But again, I'm not sure if, last time I checked, it was a little bit hard to find that shoe.
Thank you. Somebody asked if physical therapy exercises would help you to not lose cartilage.
Well, certainly we know that staying stronger is going to be healthy for your knee. That's why I mentioned probably the most important thing you can do is exercise, and particularly resistance exercise. So definitely strengthening exercise is going to be important. There are studies that show regular exercise can actually decrease some of these inflammatory proteins throughout your body, but also in the joint. So there's a strengthening effect, but there also is an effect at sort of a microcellular level.
Thank you. And would biking be beneficial to somebody with osteoarthritis?
Biking's great because it's non-impact. Um, the only thing I would caution against is don't torque the resistance too hard because that could put a lot of stress on your knee. And just make sure that whether if you're in the gym or your own bike, that you're fit properly. Because if you have a bad fit, that could also create, unnecessary stress on the knee. But cycling's great, particularly if you're doing it more lower resistance but higher cadence. That can still give you a great aerobic workout. It can still help you build muscle strength.
And would ice be useful in controlling inflammation?
Um, Not really. I mean, if your knee is swollen, it will help with the swelling, but it's really more helping with symptoms. It's not something that I would do on a regular basis. If you find that you're having to ice all the time, it tells you you're probably overdoing it.
Can you comment on hydrogel or coral plug implants?
Those are newer, but I can't say I have a lot of experience with those. So it's not something I'm typically recommending at this point. Um, and it's not something that insurance is improving at this time, to my knowledge. But it might be something in the future to consider.
Thank you. What do you recommend typically as a starting point in terms of the supplements, the hyaluronic acid, the PT?
Yeah, so you don't want to like have to do everything at once. I think particularly if you come in sort of early on before things get too bad, um, starting with physical therapy, strengthening the muscles, that's number one. If you're overweight, weight loss, I think would be really important. Um, I'm a big believer in an anti-inflammatory diet because that's just going to help your overall health as well as your knee function and pain. In terms of supplements, I do often recommend the glucosamine and chondroitin, and recommend trying that for 3 months. If it helps, great. If it doesn't, no harm done. The turmeric is also one of my go-tos. So a good turmeric or a curcumin supplement. After that, the other things I talked about, those are more second line types of things. But that will get you started.
Thank you. Could you comment on the efficacy of compression socks and topical analgesics?
Yeah, compression socks, if you have a lot of swelling in your legs, um, I think it's worth considering. Um, the topical analgesics, do you mean like what I talked about, like the topical anti-inflammatories? Um, so those can definitely be helpful, and I prefer those over taking a pill anti-inflammatory. Um, so those can definitely be helpful.
Thank you. Okay, I'm seeing a lot of thank yous. Someone's worn some Atlas sneakers, found them very helpful. Other people are feeling a lot more confident about their next doctor's visit now with this information and knowing that there are alternatives to surgery. So lots of thank yous in the chat. And to answer everyone's question about the recording, yes, this will be posted on the Health Library website and also on the Stanford Healthcare YouTube. So thank you so much, Dr. Fredericson, for sharing all this great information. Thank you to our audience for joining us and for all these great questions. If you'd like additional information or resources or have additional questions, please contact the Stanford Health Library, and we hope you'll join us for our next lecture.
Great. Well, thank you so much. I really appreciate the opportunity to speak to everybody tonight. Thank you.